Good morning, everybody. If I think it's still morning almost everywhere. Might be afternoon if you're on the East Coast. Nice to see you all. We're going to wait just a couple minutes, wait a minute or two to let everybody filter in from their last session. Brittany made me make sure that there was plenty of time between sessions for coffee breaks and bio breaks and stand up and stretch your legs break. Really excited about this session. You're filling up. We'll wait just another minute. We'll wait till 11:01. All right, here we go. So excited to be here today, and I hope you all are as well. I hope that if this isn't your first session, you've been enjoying everything so far. We've got lots happening, lots going on, and I've really been excited to bring you this session. So as everybody keeps coming in, we're going to go ahead and get started. Today, we are in for some true groundbreaking work and insight with a subset of the cancer community, which has perhaps been overlooked for just a little too long. We're going to hear findings and outcomes from the first national survey ever done to look into the unique challenges of the LGBTQ cancer patients and what their families face as well. At Livestrong, we talked earlier and you heard Greg talk about listening, and this is something we're really looking forward to hearing all about. We are privileged to have members of that community with us as well to share their stories of courage in the face of cancer. And first, to really present to us the findings of this groundbreaking survey, I want to introduce you to Scout. He is the Executive Director of the National LGBTQ Cancer Network. Scout, thank you so much for your work. We're excited to hear all about it, and the gallery is yours.
Thanks so much, Suzanne. Yeah, we're really excited to be here as well, too. I think that this is an aspect of cancer care that people don't always consider, and not even just care, but kind of access to services, even screenings, and then what happens all the way through cancer care. Just to kind of frame it as a starting point, we know that the LGBTQI population has barriers to care and a history of discrimination related to service providers. And then if you think about it, of course, anybody who gets a diagnosis of cancer quickly becomes kind of a frequent flyer of healthcare providers. You see so many people so quickly that we were very concerned. We had actually run a survey similar to this about a decade ago. And from that, we were really concerned about some of the stories that came out of it around experiences related to service providers and families and support networks and things like that. So as we go, and I'm gonna flip over to the findings from this survey first. And then, like you said, we've got some cancer survivors here to kind of bring some of those experiences to life. But I also wanted to kind of frame it with some of the stuff that we had heard earlier from that first survey about a decade ago. We know that people talked about like how challenging it was to have to come out to providers again and again, how there were structural issues that made a difference as to whether people felt free to bring their full self to the table. Like, for example, if your local hospital had the word saint before it, there's a history of discrimination against the LGBTQI communities there, and that meant that people would often come into care with some sincere reservations. We also heard some real horror stories, honestly. Like people talked about having different types of social support networks. Sometimes they talked about how they were not being acknowledged and recognized. And also sometimes we just got some really heart-wrenching information about the difference in how our community sometimes shows up and presents related to a cancer diagnosis because of that lack of social support. One of the quotes from that first survey that really stood out is one from a young woman who had gotten a cancer diagnosis. And when she informed her family that she was going in for surgery related to it, her family responded by saying, "Good, I hope you die." And so there's this just like so many layers of places where people have social support challenges and experience discrimination in real life. How does that all then manifest itself as we can think about cancer care? And is there a chance that between 10 years ago to when we did the survey now, that maybe some of this environment has changed, maybe it's become more welcoming? So with all that as a starting point, let me go to the PowerPoint here. And I'll talk to you about what we found out from our current survey. There we go. And also thank you to Bristol Myers Squibb. They are the by far premier funder of the survey, and they allowed us to get it out really quickly and kind of bypass some of the slower ways that research is being done. So we're really happy about that. I also just want to say, like that first survey, we got 300 respondents. This time, I was hoping for 600. But one of the first things we found out, well, one of the last things we found out, I should say, is that we ultimately had 2,700 people chime in to talk about what their cancer experiences were. So we are sitting on a wealth of data related to this. And what you're seeing now is these findings is the beginning of what we hope will probably be a year plus of more and more information coming out as we continue to peel back different layers of the onion. So with that, I also want to talk about who's here today. We are so honored that as a result of this, there's about 1,200 cancer survivors who said, hey, we want to be in contact ongoing, and we want to think about opportunities to engage more, be involved in research, and or speak up about our stories. And so actually, 2 of them are here today. We'd originally planned to have 3, but I'm very sorry to say that Danny Askini, who's currently undergoing cancer care, unfortunately is in the ER this morning with a fever. So all of our best wishes go to Danny, and I will I'm pretty familiar with her story. So I'm going to kind of chime back in and talk about some of the elements of her story that we think illustrate this. But the people we do have here today are 2 amazing folks that we're really honored to be able to work with. Tony Kristen Walker and Daniel Garza will both be speaking after me, and again, talking about their experience and all the intersectionality of the whole people that they bring to the cancer, the cancer journey, and talk about kind of where that was a success, where that was less of a success, and what kind of things we can think about might want to change in the cancer world in order to make it more welcoming for people like all of us. So first, let me go through a little bit related to the methods on how we did our study. It was kind of really a very community focused, and it took a village in order to get these 2,700 respondents. But just first of all, the criteria, you obviously had to have had cancer, had to identify as some version of queer, LGBTQI+, 18 years or older, and currently live in the United States. It was about a 30-minute long survey. It was all done by web because it was all done during COVID times. We initially were very happy that Earl folks from the Center for Black Equity stepped in to be an early community partner with us. They are the organization that works with all the Black and Brown prides throughout the country. So we worked a lot with all their associate organizations to try and help get the information out as far as possible and diversify our base of respondents. But beyond that, we actually had over 100 organizations who also agreed to be promotional partners at all different layers, including like Livestrong, including Stupid Cancer, some of these big cancer organizations, but also, as you can see, some of these much smaller community-based organizations, fraternities, things like that. We're really interested in making sure that this information got out because we were all as invested in making sure that we could hear the voices that really had not been listened to. These are samples of some of the promotional materials that we put out. I know, Suzanne, you all put some of these out on your feed as well to make sure we could get as many respondents as possible. And then as I had talked about, that ultimately got us 2,700 respondents. Sorry, my screen thing seems to go 1.5 slides at a time. So we'll deal with that. So what were the demographics we got as the result of it? I will tell you flat out, we put a lot of staff time and a lot of partner time into ensuring we got as diverse a sample as we wanted. And I will say our goal was not met with that, despite all of that effort. We still had some interesting biases in how our samples put together. So we know, for example, it's almost twice as much male as female. There's under sexual orientation, you see that it's actually only about 4% bi and 2% pan. We know in our population that that's actually about 50% of the LGBT population. So there's real underrepresentation there. And in a similar way, the fact that we had 3 and 2% trans, genderqueer, and then another 2% non-binary is a much lower of the population than we would expect to see. There could be a couple different reasons for this. It could be an artifact of the way we did the outreach. It could be an artifact that people in some of these extra vulnerable categories are not as willing to speak up. It could be that they're a little bit more consumed with actually trying to stabilize their own lives right now. And of course, a piece related to this is it could be that there's fewer survivors in some of these categories as well. You can see, not surprisingly, a lot of our respondents came from some of the biggest, most populous states around the country, and the ones that kind of leaned a lot into outreach. We're really excited, actually, if you look at that 15% of our population that is rural, to think about what that might mean as we look at what was the experience of rural cancer survivors versus people who are urban or suburban. Because of course, as we know, it's such a difference if you're in a city, and if you have that one hospital closest to you that has a saint in front of it, but there's another hospital 3 more blocks away that doesn't. And that's not the same thing when you're in a rural environment. So that's going to be one of the things we think will be very interesting as we continue to dig through these findings. Had a pretty good age range, especially considering this is, cancer is often considered a disease of aging. We did not have as much diversity in race and ethnicity, despite a lot of effort to put into this. So again, for the same reason as some of those other categories, it could be that some of this population is not as comfortable speaking out. We didn't actually get to them. Maybe there are fewer survivors, all sorts of interesting things like that. But we did have over 400 respondents who are Black, Indigenous, people of color. So look for February. We're actually going to have a special report on those 400 respondents. So we're really happy about that. And similarly, education was actually a pretty good range of education. We did it all online, so it would make sense that there's going to be people who are more lean towards higher education. And since it was during COVID, we had the additional bolus of information asking questions about COVID. And from that, one of the interesting things we were always looking at was, what's the sense of how connected you are? And what does that mean? We know from existing information that the LGBTQ plus community often is less socially connected, or may be reliant on a fewer number of people for our social connectedness, because in many places, in the sociological world where you develop your relationships, it could be your neighborhood, your work, your family, people in your home, and your friends. As you can imagine, if you're LGBTQI, some of those may not be as welcoming, and you may not be developing as many close relationships there. So we were really interested to ask this about folks related to COVID. And interestingly, while it may not be surprising, you could imagine it with the general population too, social connectedness really changed related to COVID. Many more people were socially isolated. 82% of the population was more socially isolated after COVID. That's a bad sign. And I will say, if you were also able to read some of the actual comments about what people talked about, of course, we know people with cancer, it doesn't just start and then stop one day and you're back to normal. You have years of being immunocompromised and concerned about those issues. So that means a lot of these cancer survivors are probably being much more assiduous about how far they stayed away from the rest of the population with a communicable disease. So when we were reading the write-ins here, we were really struck by the level of isolation that so many of these survivors were dealing with related to COVID specifically. We're happy about the safety of staying farther away, but that social isolation is bad for our health as well. One thing that I suspect is actually being debated on a lot of different cancer fronts right now is this issue of telehealth. It's one of the things that got turned on, very hastily because of COVID, but for some people really ended up being something positive. And we were happy to see that 75% of cancer you think of as a very in-person care, but 75% of the people who had cancer and were dealing with telehealth were very satisfied. And then even, only 14% were dissatisfied. That's a great attestation for a service that is kind of brand new and was turned on really quickly, and something I think we need to think about at a national level. I know as a result of this, we've actually started some social support services, which were able to be started because of those telehealth exemptions. So what we really don't want to have happen now is those advancements be rolled back just because we're like, COVID's over, so we don't need any of that anymore. Because in some cases, this really was a silver lining for rare populations like us. And then you see It's kind of hard because you don't have a population comparison, but we are concerned about the number of people who are much more pessimistic about their health after having tried to live through COVID and the pandemic. You also see, and this is echoed across our population, 27% of our population was saying that of the cancer survivors were saying that they had lost employment as a result of COVID. This is much higher than the general population. We also see, and this is when you get down to the individual level, 31% of people, and this would go up if you're BIPOC, were saying that they were delaying screenings or treatment. This is a big concern across the whole cancer world. But we have people talking about they were not doing their cancer surgeries, not even counting the many of us who might be delaying our screenings, and we're hoping we can entice these people back to the providers. And when that's the case, if we're already a group that's likely to have our cancer found later than the average person, what does it mean when we also have that pandemic gap? You can see some of the examples from the participants here. And people did also talk about this idea that they were very scared to go in the hospital because without being able to have any people visit in the hospital, and when they were, again, kind of more isolated to start with, it became a really traumatic experience to be in the hospital. So what were people saying in the main, if we go beyond COVID, what were the main findings that we kind of came out as the 4 different big themes that emerged as a result of this survey? So the first takeaway we see, and I'll just say, none of these are a surprise to us whatsoever. Maybe there's some good news in here. As we want to highlight the good and the concerns, the challenges and the successes. But the first one we were not surprised about, but happy about in one way. People were generally reporting that they could get to welcoming care. That is lovely. Maybe that's a shift from the survey from 10 years ago. That would be really great. The big caveat on this is there's really 2 big caveats. One of them is it wasn't the same for all populations. And 2 was that journey to welcoming care was often quite a journey. So just as an example, people reported that a lot of their providers were culturally competent, the ones that they finally chose. 84% said all or most of them seemed to be culturally competent and were not negative. But on the other hand, that was much less the case if you were anybody who was non-binary, transgender like myself, or somehow did not present as the standard gender binary. So then you were less likely to get people who are culturally competent. And then if you're a Black, Indigenous, or person of color, you're twice as likely to report unwelcoming care as the white population. So again, if you're in any one of these disparity populations, the news was not as good. And just to actually kind of contrast again, remember that for a lot of the population, you'd expect every one of your providers to be culturally competent. So we don't want there to be a routine where any group of providers isn't. Our goal would be to make sure that that 0% would not be. And then, like we talked about, the journey to get to those welcoming providers was longer and took more effort. If you're from the, anybody who gets a cancer diagnosis, this is an urgent deal with it now situation. It's not a situation where you want to have to be worried about making sure you can find good care because you're worried about your closest care. So, this is one of the quotes we saw repeated at Fair Peace. Getting there was painful, demeaning, and expensive. And we also asked people, how did you find those welcoming providers? I would say one thing that's not in here, which is pretty scary to us, is the idea that only 12% of the people in the survey said that they were able to find any indication that their provider was welcoming. And that's something I think that we should easily be able to fix in the cancer care world. It should not be that 88% of providers are showing no information about whether they're welcoming to this population. So people had to be creative about how they found these welcoming providers. One person decided they were going to look up their IVF policies to see if maybe they were welcoming, which I think is really innovative, and I respect that. Another person, and this is what we always recommend, was trying to find out if the providers had any pronouns after their name. It is the easiest way to show that you are LGBTQI aware And it doesn't mean you're part of the community, but it just means you're considerate. People had to go out and look for references, ask their friends who might be welcoming. And so you can see this theme that people had to go through several steps to figure out who is that provider who's going to be a good home for them. Takeaway number 2, we have alternate social support structures, as I kind of talked about with those kind of 5 areas we build social support. For us, not all of them may be as open as they are for the general population. And we have all these alternate social support structures. At times, it's a challenge to get them recognized, but also please remember that this for us can be a real source of strength. So we can see this again in some of these quotes: my tribe to this day are my rock, my family, but my family is not my rock. But having the tribe with me made all the difference in the world. I owe each of them so much. And then you can see that we also struggled with this, the social support. We need more social support in our lives, especially with COVID-19. Receiving that support and contact with others was so much more difficult, which compounded the oppression and isolation that many of us already experience. And then to note on the right here, unlike the general population, most of us were saying the person we brought as a primary support person was a friend. It wasn't a partner and it wasn't a family member. So again, it kind of shows you how we build our support structures differently. And as much as the hospital system is actually supposed to be acknowledging those and recognizing them, remember that friend has no legal relationship to us. And it's very different in a hospital system when you are someone who does not have, you're not the legal next of kin as far as how that hospital treats you. And then you can see here another quote from one of the people: we need to have more support. My experience is very bad because I lived alone, and you can see completely without the family. I will say one more thing about that social support is we have actually, and as a matter of fact, I think our facilitator is listening today, but we have actually, as a result of this survey, started the first national Zoom peer support groups for LGBTQI cancer survivors. That was the resource I was talking about that, the telehealth exceptions have allowed us to start. And we really hope now that we can keep that going. So do please share the news, and we're going to be coming out with promotional materials about this stuff soon. That if people are looking for that kind of support, Zoom is making it possible. Zoom and telehealth exceptions are making it possible now. So takeaway number 3 is we really wanted tailored resources. And that means not just general population stuff, but stuff that was talking to us about our experiences. Now, a lot of people talked about the fact that they could provide cancer survivorship resources. Absolutely, they could find them. 83% were able to find cancer survivorship resources. But on the other hand, only 13% were able to find them, but were able to find such resources for that were helpful for the LGBTQI communities. So there's a real gap in information out there for our population. Oops, there's my crazy mouse stuff. And people were talking about how important these resources were. Just as an example, 58% of folks thought that it was really important to have tailored resources in post-treatment care plans. And if you're a BIPOC, that was even more important for you. And, just as a way to make this very down to earth and real, look at the quote on the right there, where the person's talking about, they're getting cisgender heteronormative information about sex after cancer. And that completely misses the mark for them. It is absolutely useless for them. And this is something that is particularly compounded when you talk about, for example, anal cancer rates. Anal cancer rates are going up 4-fold right now, which is largely attributed to the long-term HIV positive, to the numbers of long-term HIV positive people who are now getting anal cancer, because it's been a couple decades that their body hasn't been able to clear HPV, one of the primary cues for anal cancer. And so there's a population there's a type of cancer that is really affecting our communities. And yet to get no information about what sex is going to be like after cancer, again, is a huge miss for this population. So there's a lot of different areas where we want something that speaks to our experience. And if you just hand us a cookie cutter piece of information, you've missed. Our last takeaway is that, people, particularly in some of the comments, reported some difficult provider interactions. And our concern might be this is a result of implicit bias. There was a study about 5 years ago that showed that 80% of first-year medical students showed some implicit bias against the LGBT community, and that wasn't even counting the T community, which usually incurs more. So those are the people just coming into the medical system, not even counting the people who've been in the medical system for quite a while. So there's a lot of ways that this leaks out in microaggressions, in avoiding someone's pronouns, or in misgendering someone. And that's not the kind of thing that anybody should have to be dealing with related to cancer. This is just an example on this slide of something we actually heard a few different times, of kind of a brutal reaction from a provider. And then also, as some people brought up, what was considered to be culturally competent or culturally aware services kind of seemed to be all over the map. Some people were not aware of their own biases, their own subtle homophobia. And as they talk about here in the mental health services, that was a real challenge to find the kind of care that they wanted to get out of this. And just one more note related to that tailored resources. I was almost kind of surprised the number of people who wanted just a level of tailored resources, all the way down to the fact that we wanted LGBTQI tailored physical activity recommendations to help avoid cancer. And so, you wouldn't think that'd be something that would be population specific particularly, but it shows you again the power of speaking to the community and speaking in a language that the community is going to listen to and understand and respond to. And these days, it's not like, as I always say, it's not like Mad Men era of the 60s where you have to get a Madison Avenue advertising firm to create your materials. Lots of us are doing social media shareables and things like that as small in-house efforts. So considering so much media is less expensive and does not have the developmental cycle, you don't have to buy a spot on TV anymore. There's really, I think, no excuse for us not to make sure that every provider, just for all underserved populations, is doing work to reach out and speak to the underserved populations in a language that resonates with them. And with that, I just want to I'll briefly go through what's next related to this survey. And then we're gonna, like I said, switch it around and listen to the survivor experiences and then start to talk a little bit. And please feel free to think of your questions, because we want this to be a time where we can listen to you as well. There's no bad question at all in the world. So as far as what's next, again, we're very honored about the number of people who shared an important part of their lives with us. It actually is kind of unleashed for us events like this, where we're bringing more survivors to the table to talk about their experiences directly. And so we've gotten lots of requests for this. And so we are more and more, going back to those 1,200 survivors and saying, is anybody willing to speak up to this pharma company? Or is anybody able to speak up to this, breast cancer blog people, things like that? Talk to us about what it's like for our population. And we love the fact that people are more interested. But our most immediate things that we're going to be doing, we're right now working on our gender expansive report, which is going to highlight the experiences of people who are trans, non-binary, things like that. And that's going to be out with Trans Visibility Week, which is November 20th range, something like that. So look for that in the very near term future. And then after that, we're going to be doing our BIPOC report, which will come out at Black History Month next year. We're also working on a series of peer-reviewed publications, and we're doing a lot of analyses. So like we want to, have sheets on our website about this is what survivors have said about this, things like that. And of course, the reason why we ask this information is to help make changes in the actual cancer world. So we are incorporating it into our trainings now, but we're going to continue to do so, including coming up with a series of new best practices for practitioners that we hope will usher in an era of more information. But also we're getting interest from places saying like, hey, you're right, I see that there's not information available. And so, we're getting some people interested who are like, how about if we help to create some of this information, which is great. We do not want to create all the information ourselves by any means. We just want it to be there so we can point people to it. So if you're with an organization that's interested in tackling kind of, digging into an LGBTQ lens of whatever your specialty is, let's talk. There's a lot of work that can be done. And with that, if you're a fan, we've got a couple different ways that you can help us. We would love it if people leave little blurbs on the Great Nonprofit website right now about what you feel about our work. And then we're also part of the CFC in case you're a federal employee. And with that, this is us. Some of the people are actually in the room right now, as a matter of fact. And now let's turn it over kind of the real people we should be listening to. I'll just get out of the way, and let's maybe go to Tony first as a possibility. And Tony, if you can come on, get yourself off mute, and give us a little bit of an insight into what it's like being Tony as you got your diagnosis and went through some of your care. What are some of the steps for care?
Can you hear me?
Yes. And
All right, so I got a bunch of disclosures before I start. So not only am I a cancer survivor, but my cancer journey started with me living with HIV. So I've been HIV positive for the last 20-some years. And what was interesting for me was I was going to our Ryan White clinic. For people who don't know what Ryan White is, it's pretty much a clinic that's funded by government funds for people living with HIV. And these people deal with LGBTQ people all the time. They deal with a lot of Black people all the time. And so I'm going to this clinic, and I presented in December of 2013 with some issues. I was having pain when I would, defecate, and my doctors pretty much ignored me. So even when we talk about the mishandling of LGBTQ people in medicine, there's a mishandling of Black people first. So that was December, and literally from December to July, my provider, the nurse, nobody would listen to me about my pain issues. By the time I finally got my diagnosis, which was in October, 2 months before, they told me, well, just alternate Tylenol and ibuprofen for your pain. No one, the doctors who I initially told about my symptoms, they just listened to my symptoms. I am not a doctor, nor do I play one on TV. So they just said, okay, he's got internal hemorrhoids. That's what we're gonna treat him for. And when I changed my diagnosis, they kept going with my original diagnosis. So it wasn't until I saw this nurse practitioners are the truth. And she was like, well, come in tomorrow and we'll do another exam. The first thing this woman did was a rectal exam. And I was like, I've had more action than that on first dates. My main doctors had never done a rectal exam, and they're treating me for what they thought was internal hemorrhoids at the time. It took a while later, but eventually I got my diagnosis of having colorectal cancer. Needless to say, I was pissed because this was 9 months that had gone by in which I could have been getting treatment. So that was on a Wednesday. Friday, they made a referral to one of those hospitals that start with Saint. And I went there, and immediately they wanted to mark me up for chemo, mark me up for radiation, and told me that I was going to have a permanent colostomy. And I was like, there's nothing else we can do for this? And they were like, no, this is it. So I was like, I need a second opinion. And so I ended up trying to get a second opinion. And at that time, this is 2014, gay marriage was not legal. My husband at that time and I had a civil ceremony, but I was not on his insurance. I had insurance, but it was an HMO, so it sucked. And they didn't take it at the cancer treatment center that I ended up going to. But anyway, so we had to hitch up the wagon and the kids and drive to DC so we could get legally married so that I could get on his insurance. And once you have one of those life-changing events, they put you on the insurance immediately. I was able to go to the cancer treatment center where I got treated, and the world seemed to divide. So at the place where I should have been taken care of because of my HIV that dealt with gay people all the time, I felt like, okay, maybe there's a little racism going on here because no one offered to do anything extra. I almost felt as if they thought I didn't have insurance, so there's no reason to do some tests that he can't afford. And I had very little control over, my destiny there. Transformed to this place in the middle of Georgia, like Georgia in the South, in this small town in Georgia in the South, my treatment was totally different. I was afraid that when I got down there that, being the fact that I was gay and I had a whole husband and kids, that I would get treated differently than I did at the place that should have been affirming. Actually, I got treated better, much better at the place that I didn't think it was going to be affirming than at the place that I should have been affirming. And they affirmed my LGBTQness, but they didn't affirm this beautiful Blackness that I had. And it was obvious in the way that I was being treated. So fast forward, we go through 6 weeks of chemo and radiation. And they were hoping to shrink my tumor so that they could just get rid of it that way, but that wasn't to be. I ended up having to have the permanent colostomy, but the difference for me was I felt like my body is ultimately in control. But I felt like I had a little control because my doctor told me, like, these are your options. This is going to give you the best outcomes. We could do this, but you may be wearing Pampers for the rest of your life. So you got to decide what you want to do. And I opted with, having the bag. The surgery literally was gut wrenching because they wrench your gut to change your orientation of where you poop. But that was 7 years ago, 6 years ago. I'm actually in Georgia now at a follow-up appointment. I just left a follow-up appointment this morning. There's some things that they want to kind of relook at, but I'm still doing fine. But the one thing that I want to always let people know is you have a say-so in your care. I felt at my clinic that I went to for my HIV that I had no voice. I had to take whatever they said, even though I was fully employed with insurance. But however, at the cancer center, they really let me guide my own, buggy down the street, which was a great experience for me. It was a great experience for my family. I liked it so much that I actually volunteer for them now. One of the things that was an issue for me was the fact that I was 46 years old. I'm 54 now. I was 46 years old when I was diagnosed. And so, like in the HIV world, I think it started in drug abuse and mental health, how they have peer support specialists who help, guide you and shepherd you along the way. And so they had these peer support specialists for cancer. But all the ones I talked to with my particular cancer were like 81-year-old men who told me your life is going to go back to normal. And I'm like, I'm 46, you're twice that age. We have two different definitions of normal. And so one of the reasons why I decided to volunteer was, one, I never talked to anybody who was Black. I didn't talk to anybody who was gay. And I didn't talk to anybody who was still young. So, my way of kind of like giving back was to use my experience as an HIV positive Black gay man living in the South who had cancer, to whenever they have people who fit those demographics or even close to those demographics, that I can be the person to let them know what their treatment is going to look like and what their care should be. I had a lot of fears and interpretations going into this, but I mean, honestly, my cancer journey, was actually one of the highlights of my life, and I'm still here for my kids and my family and the people that I serve on a daily basis. Scott, I hope that's what you need.
No, that's great, Tony. I really appreciate it. And it's interesting also because, you talk about the unexpected twists that your care took. So help me, when you were talking about that first place that should have been more welcoming because they were the HIV provider, was that the Saint Hospital or was that your HIV medical home?
That's the HIV medical home. They referred me to the Saint Hospital, and they actually treated me better than they did at the HIV clinic.
Oh, that's all kinds of weird. And then you did mention that at that second hospital you went to, the one that you volunteer for now, they may not have been quite as affirming of your beautiful Blackness. And you said you could tell that, but I don't think you talked to us about how you could tell that and what that kind of means for someone.
Well, I mean, again, we have a lot of things going on with people who live in the margins, who are marginalized, whether you're Black, whether you're Latinx, trans, we all have issues that come up with us. But being in the South, this is like the home of the Confederacy, like the slave states. Every possible bad outcome of health, if you have a red map on it, it's these states. So, I and that also includes my gayness, because like I I don't want to be tokenized, and I don't want to have special treatment because that means you walking in privilege. I want to be treated just like everybody else. And at that hospital, they treated me just like they treated everybody else. And that's all we can really ever hope for. I mean, that's one of the reasons why all of our movements, whether it's civil rights movements, gay rights movements, trans movements, we want to be treated like everybody else. And they were able to accomplish this. And for me, that was amazing. For you to see all of my levels of intersectionality and give them the space and the care that they deserve.
I love hearing both the promise and also, like, we know some of that journey to get there. All right, let's turn it over now to Daniel Garza, a guy who's been doing so many things out in LA. My favorite is he's also a part-time comedian. But Garza, you had an experience that, again, had many different layers of kind of your journey related to cancer. Talk to us about that.
Sure. Hi, everybody. Am I coming through clear? Hope you can hear me. So hello, I'm Daniel G. Garza. I live out in Laguna Beach, California. And yes, I do stand up. I'll do a show afterwards, I guess. But my journey, actually, Tony, listening to Tony, and I've heard Tony speak before, so I'm a big fan of his. And by the way, Danny, who is not here with us, we send you the best wishes. I'm also HIV positive. I've been positive now for 21 years. September of this year was, this year will be, 21 years I celebrated. Disclaimer is that I've been doing HIV education and research for many years, teaching at high schools, colleges, universities. And when I was diagnosed, and here come the jokes, I was diagnosed on Cinco de Mayo, May 5th. And I told you that's how Mexican I am. I was diagnosed on Cinco de Mayo. But when I was diagnosed and we found out it was anal cancer, the frustration, first of all, the frustration was that I had been teaching for many years about HIV and side effects of it and other conditions and diagnosis. And for some reason, I had never, in my whole presentations, ever talked about the cancers, and realizing that HIV positive people have like a 35% higher risk of cancers than people without HIV. And I was like, why did I not know that? And then I realized that that was something that I had never talked to with my doctors about. And I found that really interesting. Second, I had a really great doctor at the time. He's retired now, but he was an amazing doctor. We've been together for a long time. But when I started having issues because of the cancer and like Tony, like let's talk poop. There was nothing coming out, and I would go to my doctor, and he's white, I'm Latino. Culturally, there were some differences, but I always thought that he understood those differences until that moment. Again, I still love him. We still stay in touch, but his answers to my not being able to go to the bathroom or having issues was my diet. It was always about, what are you eating? What's your diet like? Are you eating too much tortillas? What about that rice and beans? And I was like, no. And because towards the end, before I was diagnosed, I was literally on a soup diet. All I ate was soup most of the time, liquids, because it was so difficult to go to the bathroom. It really came down to, I had a hernia and I was having issues with it. It was a strangulated intestine, and we were like, oh, there's the answer. That's why you can't go to the bathroom. And ended up going, got my surgery, went back for the checkup, still not be able to go to the bathroom. And these were painful times. It's basically a plug in your butt and you can't do anything about it. And like I told you, I was working, I was active. Most of my jobs were out in the field doing promotional work. So I was always running around, and running around when you're that bloated and sick and tired, and then you're sick and tired of being sick and tired because you don't know what's going on. After the hernia surgery, when they went back and did a checkup, it was actually the surgeon that did the probe, and he was like, I think I feel a mass, let's get you checked. And that's what started the ball rolling, no pun intended, to figure out what was going on. I went, still, my primary doctor was still kind of like, I don't know, I don't think so. Like I was 44 at the time, and we hadn't hit really that age where it's like, go get, colonoscopy, go get checked. but we immediately did one. They found a solution. They found what the problem is. But I want to throw some good highlights here. I had a doctor, and his real name is Dr. Rad, and Dr. Rad is pretty rad. Just to put that out there, is one of those doctors that always looks good, always smells good. So as a gay man, I was always happy about that. It's like, yeah, come on in. Especially if they're going to probe your butt. You want somebody that looks good, right? But back to seriousness. When they did the diagnosis, and again, we were heading for a Cinco de Mayo party, and I was having just really bad problems, and I felt icky and sick. And he was like, "If you can get here in the hour, I can give you your diagnosis." And I knew what that was. At that moment, I knew exactly what it was. Because for everybody, they don't call you back into the office, to celebrate your good health. And so we walked in, and he sat me down and said, "It's anal cancer." And I was like, okay. I'm not a crier, but there were a couple of tears that shed there. I'm a Mexican macho, I gotta hold it together. And now the cool thing about Dr. Rad was that he leaned over, got up from his chair, leaned over on me, put his hand on my shoulder, and looked at me in the eye and said, "Look at me." And I was like, "Yeah, I'm okay, I'm okay." And he's like, "Look at me." And I was like, "No, I'm good." And the third time he said, "Look at me." And I looked him in the eye and he said, "We got this." And it was one of the first times ever in my history, my health history, that a doctor said, "We got this. Not, you're going to be fine. Everything's going to be okay. Don't worry. No, we got this." And I said, "We do." And my partner was there with me, and we're not married. So that was a big concern. But luckily we had people that guided us along the way. It's like, fill out this paperwork, get these forms ready, have a binder, bring it with you to every appointment. Had some emergency visits, bring that binder with you, make sure that people know who you are. Now, I was really Catholic. And so the Catholic side of me sees something that says saint, and I'm like, "Vámonos, let's go there. Like, Jesus is with me, but Diosito is going to protect me." But I ended up having to go to a county hospital for an emergency here in Culver City, near my boyfriend's house. I live in Laguna Beach, which is an hour away. And there is when I had the most issues. There were nurses, culturally different, thought different. There was a lot of discrimination because we were gay, and it was very obvious why they were doing it. I was under a lot of pain, and the way they were treating me when I was in pain really gave me a sense of how people can be treated. Now, I'm going to say this, although I'm Latino, I was born in Mexico. We moved here to the States when I was 3. I've always considered myself first generation because I basically grew up in Texas. But I'm also part of the, when we talk about privilege, I'm part of the Latino privilege. And a lot of people don't think about that because I'm bilingual, I'm educated, I'm an advocate, I know how to take care of myself, I'm very vocal. And as you can see, I'm not shy about sharing anything. But there are a lot of Latinos that don't. There's immigrants, undocumented, monolingual, who are fearful. And it's culture, religion, and social norms that put us there. And we think as Latinos, I can't say anything. No digas nada, no digas nada. The doctor knows, don't say anything. Don't get them mad because las enfermeras son malas. Nurses are bad. And there's a lot of things that really as a culture, we have been fed by our parents. And I understand sometimes there was undocumentation, there was language barriers. So they did what the doctor said. But I think that sometimes the healthcare professionals, not all, because I've had some amazing people take care of me, but there are a group of people in the healthcare profession that use our personal fears. I don't know if it's a power thing. I don't know if it's a control thing. I'm better than you. But that's why I started speaking up about anal cancer, and no buts about it. Because I can, and I want to teach other Latinos, especially men, who are so intimidated to go to the doctor's office and get probed, get that checkup. I'm like, dude, it's just 2 fingers. It's over before you know it. And if you're going to get a colonoscopy, they're going to buy you a big drink to drink before you go in anyway. So it's all good. If you've been to a colonoscopy, you know what I'm talking about. If you don't, you'll find out soon enough. But it's about giving a voice to the people. And I try to speak to people in Spanish as much as I can about colonoscopies, anal cancer, and getting checked. And I'm so glad that the number is starting to lower, because it was 55 for a long time, then it went down to 45. And now we're starting to talk to people about 40. Hey, if you're 40, start getting that colonoscopy. If you're a gay man, anal sex. If you've been, I would say I had HPV as well. So HIV, HPV, and polyps and tears, anal, is what caused my cancer, the perfect storm. Now, the outcome of that, which, well, before we end up, before my time runs out, is the outcome of the cancer. What has happened since? 2015 was my my summer of cancer, and it was not the year of Aquarius, it was the summer of cancer. And my boyfriend was my caregiver, and that's another thing that we never talked about. He went from boyfriend, caregiver, and coming out of the caregiver role is so difficult. It took us several years for him to get back to where he wasn't continually worried about me and what was going to happen. Finding the right doctors again, making sure I got checked. Like I fell through the cracks. I didn't get my 5-year check. We just ended up going back this year because nobody checked up on me. And finally, somebody asked, like, "Have you been back?" I was like, "For what?" But luckily, we just got scanned. Everything's good. I'm all clear right now. Which when they did the head scan, I was like, "You want to go do that again?" I'm sure there's something wrong with me. But no, we're good. We're good. So that my partner, sex. Talking about sex, we don't talk about it enough. There is all kinds of magazines and advertisements, and PrEP is great. PrEP is great. But there's nothing about sex after colorectal and anal cancer. How does that happen? As a gay man who enjoyed sex without being able to use my butt, like it really takes away part of who I am as a gay man sexually, not as a human, as a man, but as a gay partner. Like how do I present myself to my partner sexually if I can't do that anymore? And I've been fortunate that I did not have what they call a Ken butt, where they completely sew you. I still have a full butt. And it's pretty nice and good genes, by the way. But we don't talk about that. And the reason I use comedy is because usually we hold more information when we laugh than when we're really serious. And I want you to remember this, that and I hope it doesn't, if the moment comes that you have a colonoscopy and that something is found, just know that you can thrive and survive. And I also have an ostomy. His name is Tommy. He's been with me since I got him on April Fool's Day of 2016. That's how my life is, folks. So you know where all this comes from. That you need to talk to somebody. Start talking to somebody the moment you get diagnosed. Don't wait for therapy afterwards. Start therapy the moment you're diagnosed. Have your partner with you. Set up a support system. And like they said at the beginning, it's not always your family, because my family's in Texas, I'm in California. Start building that community for yourself. And let's talk about butts. I don't think we talk about them enough. So if you want to talk butts, call me. Thank you.
So Garza, you are cracking me up with all your stuff. Let me just ask you a question, and then I'm going to go into talking about some of the Danny story. I know, that's okay. It's a big issue in Laguna Beach these days.
They heard me talking about butts and they came.
Right, exactly. They're like, we gotta raid this man. So my question would be, so if we know that, like we do know that gay HIV positive men who are especially long-term HIV survivors should be having anal pap smears and regular checks for anal cancer because of the increased risk. And yet, honestly, we have a hard time even finding providers who know how to do an anal pap smear, much less knowing that this should be a routine. There's only one state in the country that even has a standard of care that mentions this. That's New York. So around most of the country, this is just not happening. And my question is, how does that make you feel?
Mad. I was mad. I was mad because I was 15 years HIV positive, coming into 15 years, and I had not once had a conversation about the possibilities of cancer in my life. And I was mad. I'm still mad. I'm still mad because, like Tony, I've thrived. That's what I do. I thrive, but it makes me mad that we're still not talking about it. I talked to some of my gay friends about anal cancer, and you see them freeze and be uncomfortable. I'm like, I don't care if you're uncomfortable. talk about it, because it can't, you don't have to go through this. But I take it higher. Like, why aren't doctors bringing that up? Hey, if you're sexually active, especially I'm 50 years old, we HPV, if you were HPV positive, if you're HIV positive, if you're having anal sex, bring up the conversation. Your doctor may not know how to do it. So you have to bring it up. And I think we're just scared. I mean, growing up in my family, if we didn't talk about it, it didn't exist. And I think just like HIV, if we don't talk about it, I won't get it. If I don't talk about cancer, I won't get it. But let me tell you, cancer is a mean friend. It doesn't care social, political, religious. It'll come after you. So talk about it.
All right, talk about it. Well, I think we're doing pretty well on that today, at least at this moment. So now let me kind of switch a little bit. Unfortunately, as I talk to you about wait, I'll take you off just a second. Let me take you off your spotlighting here. And so I'm going to try and convey a little bit of someone else's story. So one of my dear friends, Danny Ischini, is this really amazing trans woman. She's one of the first ones who ever ran for public office that I know about. She has been, a really outspoken and amazing warrior for trans people around the country for decades and decades now. And she also, in addition to that, is now a multiple cancer survivor. Unfortunately, like I said, because she just came down with a fever this morning, she's not able to be with us today. But a few months ago, she talked to me a lot about what she went through in her cancer journey. So let me just bring up a few of the things that she highlighted, and then we're going to turn it back over for discussion. So please get your comments, thoughts, questions, just musings ready, because we want to really have the last part of this be kind of talking amongst ourselves about this. So, I think some of the things that really stood out for me when I was listening to Danny talk about her story is that, like with Garza, like with Tony, she got to really amazing care. But it's pretty interesting because actually, kind of like you also heard with their stories, like, for example, when she was in Washington State, she got to a place where she had really good cancer care. But she now is moved and she's getting care in one of the largest and best respected hospitals in the country. And as a trans woman, her care is not as respectful as it was in Washington State, oddly. And, she also really talked about this amazing difference between, you have so many ancillary healthcare providers when you're in the cancer world. In particular, she had to have home healthcare aides during some of the most intense parts of her cancer treatment. And, we think often about, well, let's get the doctors cultural humility training or something like that, right? But you don't think about how we need to have not just the training, but the respect and a real level of accountability all the way through so many different healthcare providers, because she has been in a number of experiences where it is, in some cases, her home healthcare aides who have been the most brutal. I mean, similar to Garza, Danny will laugh about it, and we were as we were talking about it. But she told me this experience where at one point she was worried that she was going to die in the shower because she was so weak she couldn't get out. And she kept calling her home healthcare aide, who could clearly hear her and knew that that person's job was to be there to help her with things like the shower. And in what was clearly aggression related to the fact that this person did not welcome her being trans, she was not coming to get her out of the shower. So, Danny's very clear that, like, you don't want to be in the position where you're so weak, you can't do your bodily functions. And yet you have to, as a trans person, be teaching a home healthcare aide cultural competency, being expecting the cultural competency, be trying to teach them about what kind of body parts they might experience and deal with their bad behavior if they're not okay with that. And, we actually, in our launch event, which was another great event, we had a lot of survivors talk related to this survey. We heard from another woman who, we've heard this a few times now, who it was a person who went into cancer treatment congruent with their assigned sex at birth as a male. And then after they got their diagnosis, and after the provider said, this is terminal, this is a one direction here. This person realized, oh, I cannot die as a guy. I'm not really a guy. I am a woman. And so in the middle of their cancer treatment transition and, realized the true manifestation of who they were, which is great and amazing to hear. But also we heard her stories about how she was treated by the exact same set of providers. And in this case, when she, was a white guy, she got one level of care. And then when she's a white trans woman, she got a different level of care and much more subtle resistance, much less respect. And, she's not in a position, of course, as she goes through this to negotiate that and to manage that and to try and demand the kind of respect that she knows she deserves. So this is a situation that I think, particularly with our gender nonconforming and our BIPOC populations, or anybody who experiences more of a health disparity, we're at even increased risk that the kind of biases that people bring into our experiences can really harm us, especially as Danny's experience shows, when you're so vulnerable because you're just literally physically weak. You're not in a position to be fighting for yourself. So that's just another piece of this that I want to bring into the equation. And with that, Suzanne, how do we want to do it with the discussion part? Should we just be looking at what kind of questions we have out there? Do you want to come back in, or what would make sense?
Yeah, absolutely. So if any of you have questions on this incredibly interesting topic, first, thanks for all of you for being so vulnerable and open to this discussion. But yeah, so anybody who has a question, you can either just chime in, raise your actual real hand. I'm happy to acknowledge that.
We have real hands, don't we?
Yes, we do have real hands. Or if you prefer the little cartoon hand that comes up in this corner of your screen, you're welcome to do that as well. And I'll just call on you in order. I think Tony.
Yeah, this is not a question. It's more of a comment. And I've heard this with Daniel. Scout mentioned it with our trans sisters who are going through this. I wish we would throw cultural competency, humility out the window. And let me tell you why. In the South, cultural competency and humility allows white people to teach other white people to talk to Black people and brown people without offending us when they should be hiring us on the staff. Imagine how Danny's situation would have been different had she had a trans home healthcare person with her. It's interesting that we don't see this. We don't see that those disparities when it comes to having real representation within healthcare. I mean, my whole last 4 years of doing HIV work has been around what I call racial concordance, or I call it cultural relevancy. It needs to be relevant to my culture. I don't need you to just understand it. But if you're a hospital or a healthcare provider, I don't need to see a line of white men when I come in trying to help me. There are so many things that they don't understand and they don't know about all of us, and they should do more diversity when it comes to hiring processes. And that's just something that we, as a community, as a country, as a society, have to get on top of. I'm not saying get rid of them, but I mean, they don't need to be everywhere. And some of us should show up in some of those spaces. I've been in HIV care for the last 20 years. I've never had a Black male doctor. And I'm gonna let that go.
Wow, thank you, Tony. Thank you. Noel, I believe you've got a question.
Yeah, thank you so much, everyone, for sharing your stories. My question, it really struck me something that Daniel said, just that even in his own role as an educator, didn't really talk much about cancer and HIV positive communities. And I'm kind of wondering, just, from Scout or Tony or Daniel, how much do you think that the LGBTQ plus communities, recognizes that, cancer and cancer caregiving is even sort of an issue? Is it on people's radar? Do you think it's something that we need to do more about? And is that changing? Have you seen that change over the last few years?
Well,
I'll chime in. Go ahead, Daniel.
the one thing that I can tell you from my is that there were signs of cancer for a while, and I hope this answers your question. There were signs of cancer for a while, just from me feeling odd, but because of some of the symptoms like the bleeding, the swelling, the bumps, there were all these other explanations. You're having sex too rough, hemorrhoids, it's just natural bleeding, you're a gay man, you're too young, what are you worried about cancer? It was always like, you're fine. And I think that's, going back to what Scott asked earlier, like that's what made me mad, is like we could have found something out earlier. In the education part, I take some of the blame too. That's part of me too, for not doing better research on my end. But it's just something that it was never brought up, and I just never thought about it. I don't know if that makes sense, but I wish the doctors had said something when I was originally diagnosed and said, hey, these are some things that could possibly happen, because at least it's in your radar. I prefer worst case scenarios. Give me the worst that can happen so that I can go back and do my own research. And kind of to what like Tony was saying, a lot of times I saw this sugar coating, like, oh, don't worry, everything's gonna be fine. Well, no, not everything was fine. And here we are today.
Also, I think that cancer has a level of stigma that we don't really recognize. I mean, working in our field, being who we are, we know how stigma looks like for our community. But cancer in itself still has a stigma. I know several straight people who've had cancer, and you would have thought that they had like HIV or something the way there. So, oh, don't tell them I got cancer. I'm like, it's cancer. Like, it's just something that happened. Like, nobody can really blame me for this. So, like, it's not just our community. I think our society as a whole, we don't even want to talk about it. You know, down here in the South, well, I don't want to claim that. Well, you ain't gonna claim it; they'll claim you. You know, so like, there's a lot of Audre Lorde said that your silence will not protect you, and we feel like if we don't talk about it, then the boogeyman will come up. Well, the boogeyman's always looking around the corner, and you need to let people know where he is. And we do a horrible job about that as people. Not even adding in our layers of marginalization, but just as people, we do a horrible job about talking about cancer.
Thank you. That is great. Great question, Noel. I know I think we've got time for this one other one. Heather put in the chat. She says, you all are amazing. I work for a Catholic healthcare system, one of those facilities that is named after a saint. We are starting to make changes. We are starting to make the necessary changes to serve the LGBTQI cancer patient with holistic care. We are starting with education for the providers. Are there other areas that we should initially focus on?
Well, as a Catholic, thank you. First of all, let's really be with God. Let's really follow the lead. And I think that's one of the things. It starts everywhere. You can't start at the top and expect it always to trickle down, because it doesn't. You need to go full force. This is in my family, talking about what Tony was saying, like in my family, when I was HIV, there was like, what's going on? Cancer was a little more, because it wasn't considered something bad in our house. Like, it wasn't a sin that you got cancer, but it was a sin that I got HIV. So that was a difference. But we didn't just educate like my parents, we educated my sisters and my nephews and everybody that was going to be around the house on what cancer was and what pronouns. And I'll be honest, I'll end it with this. HIV opened the eyes to a lot of people in the family of how really bigoted some of my family members were, and how for years they'd accepted me being gay, but when HIV came, it was like their moment to shine. It's like, see, you're being punished for this. And here's the realization: not everybody is going to accept it, and I think that's something we have to be understand about. Talking about political correctness, not everybody's gonna be on board. Not everybody wants to be educated. Not everybody wants a gay friend, and you know what? That's okay. But then this is not where you belong. This is not where you should be working if that's an issue for you.
I recently got a non-gay friend. I was very excited. It was Suzanne. I'm kidding. Tony, you're gonna say something about this too.
I was just gonna say that for the lady who asked the question, is to diversify your staff. I mean, you know, again, it's okay to educate providers, but have providers who walked in our shoes, who know our stories, who lived our lives. I mean, that's for me, That's going to make the biggest impact. One thing that I did notice about the cancer treatment centers that I went to, that I actually put into my HIV work, was that it was amazing to me that just about everybody who worked at that place either had a cancer diagnosis themselves or they knew someone close to them who had a cancer diagnosis. The founder of that hospital, his care delivery model is called the Mother Standard of Care. When his mother had cancer, he was appalled at how she was treated. So in his mind, he wants everybody that he hires to treat everybody as if that was your mother. Would you let your mother sit in a waiting room for 15 minutes without acknowledging her presence? But also the connection that they have to that was also very important. So like even with my staff, I have a staff of 11 now. I call us the 12, biblical reference. Everybody on my staff either is living with HIV, know someone who's living with HIV, from you name the gamut, straight people living with HIV, trans, you name it, that's what we look like because that's who we deal with. I don't have to spend time teaching them how to treat people right because they know what goes on. So like we got a cultural competency training next week at work. I'm like, we don't need to go to that. We from the culture.
I would say in that same vein, I love the way you frame it as, how would you want your mother to be treated? But there's more and more of us all these days now who have someone queer in our lives and in our family. Like I was given a training at a big cancer organization and we started by asking that. And more people were like, yeah, my son, my nephew, it's all over. So maybe, Karen, a way to think about, you got to expand that training on to the frontline staff, because if we don't get past the frontline staff, we're never going to get to the doctors, right? And maybe a way to think about kind of how to frame that is to do some work on like, what is what are people seeing in their life that is their reason why they care about treating this population well? And if they have nobody in their life, might that say something about also kind of who they have and what their choices are?
Is there anyone else before we head off for lunch? Everybody's stomach growling, unless you're on the West Coast where you could still have brunch, probably, right? You could.
Well, Suzanne, you got cheesecake. You already warned us in advance.
I know.
So.
That's all Brittany's fault. We were talking tacos and cheesecake earlier before the session started. I just have to thank you on behalf of everybody in this room and everyone who's going to watch this on YouTube later. I want to thank all of you, all three of you, for being so vulnerable and so open with us. I know I've learned a ton. Mostly I've learned that I'm Scout's only straight friend, and that's no, but really we've learned so much, and we're going to take this with us. Jean even put in the chat, she's put her pronouns in her nutrition session. Just all of these small things, right, that we can take away from what we've learned today to make everybody who's going through cancer, to make their lives just a little bit better, because that's what Livestrong is focused on. What everyday cancer problem can we fix today? And this is something we can fix. So thank you all so much for joining us in this session today. And you've now got 30 minutes for lunch if you come back. So thanks a lot.
Let's all throw Danny some healing light too, as a matter of fact, right?
Healing light. Scout, Daniel, Tony, thank you all so much. Have a great afternoon. Bye.
Thank you for the opportunity.
Thank you.
Great session.